That's okay.
Yeah. Oh, fantastic. So, Colin Peters here. I'd like to welcome you all to this afternoon's WebEx, part of our series of WebEx running across the course of the year, and delighted that Gopi Menon from the Royal Infirmary of Edinburgh, specifically the Simpsons Centre for Reproductive Health, is going to talk to us today about something that's very important, and SPSP are going to be striving towards reducing mortality. One of them being reducing necrotising enterocolitis. And you tell us what Edinburgh have been doing in their efforts to bring down their necrotising enterocolitis rates in recent times. Thanks very much, Gopi.
Thanks very much, Colin. Just start off by saying that I'm very interested in the subject of necrotising enterocolitis, but I'm no means an expert. I'm certainly not an expert in improvement. So what we're going to hear is a story of what we've been up to in Edinburgh, some of the things I think we might have started to get right, some of the hiccups we've had along the way, which is really the story of many quality improvement approaches. I think that sorry, the wrong button. Bear with me, I've just got to get used to the technology. Click to the next slide.
Yes.
I think the first thing you've got to do to try and have a joined up approach to quality improvement in an area is to understand what it is you're trying to change. The condition you're trying to reduce the incidence of, the process you're trying to improve the proportion of the time that it's completed, etc. And in that sense, we've got to have some kind of understanding of the preterm gut. And I'm going to run through a schema that I developed, really try and a bit of understanding in our team and get my colleagues on board as to what we need to do. Here's together, and really a little bit of science, basic science. He looks at the gut as well as being a nutritional organ. It's a very crucial barrier to the outside world, and the barrier is quite complex. It has a very primitive and non-specific layer on the surface, which is constituted by all of those things there, and then further down on the screen, the more specific, what's called adaptive immune response, the T cells, B cells, antibodies that create a response to a particular set of antigens. It's a very crucial barrier because it poses a larger surface area to the outside world than the skin does, but it also has got to be very clever. You can see that there are a variety of things listed which you can read for yourself that add to the barrier, the specific barrier, and there are receptors on the surface of the gut that are quite sophisticated and interact with what we hope are the good bacteria in the gut to dampen down any unwanted activity with mucosal cells of the gut. So what the essence about the gut is that it's got to keep out nasty things, but not overreact when things are actually going on okay around it. A challenge, and of course, a lot of these items that I've listed here are very poorly developed in the preterm newborn baby, which is the group where necrotizing enterocolitis is a risk. I was hoping these would appear gradually, but anyway. So the schema that I produced, if you focus on the boxes first of all, that go from basic material to explosion down at the bottom right, I envisage necrotizing enterocolitis that develops over time, and you all know that enterocolitis very rarely presents very soon after birth, and the more preterm the baby, the later in postnatal life that it develops. And there are two things that help it or allow it to develop. One is lack of preparedness of the gut. That's represented in the little graphic down at the bottom left, the unprepared gut. And the thing that's important is the bugs that initiate an inflammatory response. And at each of these stages, as I say, I envisage a process which constitutes starting with the basic material, which is preterm babies, who probably have some kind of different genetic propensity to this disease. Then you have things that might provide a spark to light the kindling, if you like. And then you stoke the fire with a variety of other things, and then you get an explosion, which is really the presentation of necrotizing enterocolitis. And what I've done is marked the things that relate to unpreparedness of the gut in green. This is a very crude way to represent it because it's a complex process. And the red items relate to things that might predispose to overgrowth of harmful bacteria and promoting the inflammatory process. So there is a process that happens, and there are a number of things that happen in neonatal care that one might try and influence at each of these stages that might play a part in reducing necrotizing enterocolitis. Probably pressing the wrong button here. For this. Over the years, the last decade, we tended to have necrotizing enterocolitis rates in the 10 to 10% range, the less than 32-week gestation babies. This graph represents the less than 30-week gestation babies that we provide data on to the Vermont-Oxford network, are a part of, that looks at a specific definition for necrotizing enterocolitis. I see that at the beginning of this decade, there was quite a dramatic rise in the rate of necrotizing enterocolitis in admissions to the neonatal unit. Coincided with a desire to look at quality improvement in a number of different ways, not just for necrotizing enterocolitis. We also specifically had data on late onset sepsis in which compared unfavorably with other units on average in the Vermont-Oxford network. And it was really towards, in the beginning of this decade that we started thinking about formalizing quality improvement and went from a decade of audit and random audits to thinking, how can we improve the implementation of evidence-based care, but also inspect the processes that we undertake every day to see whether we could do them better. First thing that our unit took very seriously and looked at the Vermont-Oxford, how we measured up to the Vermont-Oxford network units, late onset infection. And that's been invented in a number of different places. This incorporated a number of strands or domains of work to do with hand hygiene and wearing of gloves, the protected days for babies into which things came in or went out. Except when you went in to press a baby, cleaned your hands before you went in and cleaned your hands before you came out. An ACES checklist for procedures, including IV lines, a formalized guideline for, firstly starting to use EBM, which we only did around that time, and producing a formalized guideline, as well as antibiotic stewardship. A whole lot of these, each of these domains broke up into quite a large number of initiatives. And they certainly succeeded. I'm sorry, I haven't got a slide to show you our success in infection reduction, but around the same period of time, we saw a reduction in rates of necrotizing enterocolitis from that peak that we saw in 2011. Of course, coincidence in time doesn't mean cause and effect, but in the time period when we saw a reduction in infection, late onset infection, you can see that we had a reduction in rates of necrotizing enterocolitis. That is the green line, compared to the yellow line, which is the mean for the Vermont-Oxford network. And at that stage, it actually had come down, and then it leveled off. But for months, we kept doing charts, and the rate was very static at that point. And I have this kind of parking slide, if you like, which says leadership in quality improvement, we were aware that there were other units where, talking to colleagues at meetings, and I attended, for example, the SIGNEC group, met regularly in London and still does, international experts, several people around the world that say to you, well, you know, we've actually abolished necrotizing enterocolitis, or you know, our last case of necrotizing enterocolitis was 2 years ago, or whatever. And so I've got to say, it wasn't just because of this, but this coincided with a bit of a laying off in rates of infection as well, and the approach to quality improvement was reassessed in our unit at that time. What up was, I thank Julie Becker, one of my colleagues, for this slide, and I've got to point out that all of the pretty slides are not mine, but belong to colleagues. What this represents is what we've called our local neonatal care collaborative, which attempts to lead quality improvement, but also bring group professionals, multi-professional groups together to lead in quality improvement. I don't know if you can see my point or not, but improving gut health. We didn't reducing necrotizing enterocolitis, we called it improving gut health. This is a group that I've been very involved with. That was one of the groups that was set up in order to try and garner interest, find professionals that were interested in a particular area of quality improvement, and then run everybody tinker in a little bit of everything. And, so one of the things I did was, I guess the first thing you've got to do when you look at quality improvement, in ways the easiest form of quality improvement is looking at areas where there is a strong research evidence base, and then do your best to implement the things for which there is a strong evidence base. I spent quite a bit of time doing this, and basically I haven't got time to give you a lot of detail under each of these, but I'll tell you a little bit of what I did. So I broke it down into individual interventions, if you like, that were thought to literature having shown I do or might make a difference. Antisteroids, delayed cord clamping, early colostrum, sustaining lactation, donor human milk. Of course, a number of strands relating to human milk. One of the most highly evidence-based interventions in terms of using necrotizing enterocolitis. The list continues with rationalizing antibiotic use, data that using antibiotics, particularly in the absence of positive cultures, increases your rate of NEC, use of probiotics, standardized feeding regimens, asepsis in handling. This is handling of expressed milk, blood fusion and its relationship to NEC, and a sort of a nebulous concept of care around the period of highest risk of necrotic enterocolitis. So you define a period round about 29, 30 weeks gestation was quite a peak in the incidence of necrotizing enterocolitis. So no matter what nation you're born, that's the period around which most babies get NEC. And is there something you can do around that time? So what I did with each of these processes or interventions was to put down in terms of presenting evidence. So, is it plausible that these individual things have an effect on the NEC? And what is the likely mode of action? What we say about the size of the effect? That's important because you want to prioritize things that might have a larger effect and likely to if you like, to be relatively easy to implement. So the various things that you might take into consideration and how you prioritize your interventions. So possibility and likely mode of action, size of effect. I tried to give an idea for my colleagues of where we are now. That is, how well have we implemented best practice already? Is still a way to go? Is there anything to be done in this area? What implications be for us thinking about this track? Because if something is very expensive, if either something's very to implement, a large effect size, or costs a hell of a lot, that's much more difficult to implement. The positive effects, because very essence of quality improvement is thinking about balancing measures. So it's very important not to create a new set of problems by trying to solve one set of problems. The standard that we ought to use as a target to aim towards for each of these items, and then recommendation based on my reading. At that point, I convened my consultant colleagues, and we had a presentation trying to decide how to take this forward. And this, again, a sort of pre-slide, so it's not mine. It's an attempt at a kind of a crude driver diagram, which is again one of the key words in quality improvement. It's not a true and complete quality flow driver diagram. But I guess one of the things you have to do to try and say what is helping you in your improvement, what is so the positive drivers, what are the negative drivers. This is one of the ways of expressing this. So, in order to drive forward quality improvement, what we did was to formally set out to try and do some marketing and try and get people in it. We've already got 2 consultants and a senior nurse. We want to get nurses involved because they're obviously very key to the whole lactation and feeding process. And we wanted trainees. So we started trying to get a gut health group together. And we really gut health because it's so positive. Rather than trying to say, we're trying to avoid necrotizing enterocolitis, we're trying to encourage good gut health. And we decided that it was better to try and promote that than to say we're going to try and avoid such and such. And good gut health equates to lack of gut injury or necrotizing enterocolitis. And every patient has its different motivators, if you like. One of the members of our group decided they wanted to call us the baby babies. So we obeyed that, and so we have a WhatsApp group that's the baby babies, communicate to each other and so on. We've made a progress, so we've got a number of medical and nursing staff, we've involved senior staff on the postnatal ward, towards the labour ward, as well as a new group of senior nurses who've been recruited to act as feeding advisors for mothers, for lactating mothers. We don't have a thing as a lactation consultant. So obviously the model for providing lactation advice varies around the UK and around the world. Some of the units in the States that do very well with this have many lactation consultants who are dedicated to advice. We don't have that. So we've got feeding advisors who are the direct interface with parents. And what we achieved, and I'm really just telling you what has happened, and this is not to be a solely success story. I'm really just relating what we've done. I think one of the things about quality improvement is you need to go out looking for new perspectives. You need to start asking people, ideally who've never worked in natal care, who haven't got all the prejudices that we've built up over the years, and the people who particularly brought new perspectives were some of the more nursing staff, and certainly one or two of the trainees. And I'll show you at least one example of one of the things the trainees have added to the group. We recruited a parent rep who hadn't yet been involved, and I think we feel that's very key, particularly if we're going to try and improve lactation success. Keeping a watch on the time while we go through these slides. We challenges. We traditionally tend to stick to our little silos. Silos are kind of overused term, but we tend to work our own little packages. Medics working in a little world and nurses working in their own world. It proved a challenge bringing a multi-professional group together, and particularly engaging the nurses to help do some of the on the shop floor, if you like, to help develop some of the work. And I'll show you an example of this in a minute. And I've got some ideas about this. And again, progressing work between meetings. So this is always a problem. I think all of us who are trying to lead a project of any sort find it's difficult to keep momentum going. So then we've fired off a whole lot of different ideas, and there's been a kind of multidimensional approach to quality improvement. And this slide of Julie Clare's showing the number of strands that, in a kind of pictorial way, from 2013. 2013, I think September or October, was when the Neonatal Care Collaborative in our unit was set up. This is really showing, in a kind of pictorial way, some of the initiatives that were undertaken. Don't try and take all of that information in. I've tried to simplify that in the slide. The initiatives on labour ward and the postnatal wards. I'll show you some examples of this: antenatal steroid audit, improving the process of routine discussion with parents, a mother who's threatening preterm labor, antenatally access very early on to kits for expressing breast milk. So, one of the tenets of good lactation is the earlier you start expressing, the better. There's good starting to do it once the baby's in the neonatal unit. Making available small DVDs, I hope you're all familiar with those, and portable DVD players, antenatally right the way through. And so we look at prenatal steroid use, which does have a very powerful impact on the risk of necrotizing enterocolitis. And then back over time in 2016, actually of 2016, at prenatal steroid rates, the bar is all delivering live preterm. The bars are those who've got those mums who've got a complete course of antenatal steroids before delivery. The green bars, or the green sections, are partial course. The red sections are none given, and there's a very tiny proportion which are known. And this is taken from our maternity database. You can probably judge that the complete course does seem to have a overruling effect. Of course, many of these annual attempt to do annual measurements, you get ups and downs, but I think overall there's been an improvement, and there's a reduction again all in the proportion of any antenatal steroids. It was useful to look at that and inform the question of whether we should be spending a lot of time on the particular issue. And I think we've decided that it's going to be looked at in the National Neonatal Audit Programme. We're going to see how we compare to other units around the UK before we undertake a large amount of work in this area. A page from our maternity patient record, which is already coming or not. I find it difficult to say that. It's tempting to say coming ready or not, but the parents wouldn't appreciate that. Ready coming or not is a tool on the maternity electronic record to try and get maternity staff and neonatal staff seeing parents to think about antenatal counselling by neonatal staff, who are the key professionals, have they been offered a look around the neonatal unit, have they been given information and small as DVD to look at, do they know what they're expecting, has hygiene been discussed? And it says at the top there, it's an aid to preparedness for their baby being admitted and for them on the neonatal unit. Thinking about this early and joining up to other important elements of care, I think has been a very important step. More Wonders DVDs, which, although it says the DVD was printed with money from Department of Health, the Scottish Government did fund Small Wonders DVDs for the Scottish units as well, and it's been routine in our unit that parents get these now, and I think they've got some particularly good videos of the approach to expressing breast milk, and it's using a different modality, if you like, to help parents at a time when reading this bundle of stuff that you might give them might be less than actually watching a video or watching another video. In the antenatal wards and labour ward. Here in the neonatal unit, we carry, I'm sorry to list here, but my animations obviously failed. But you know, there are things here. Many of you will be involved in baby-free accreditation. On the back of that, nursing staff and midwives are getting trained in best practice in communicating and how mothers lactate. Feeding champions who've recently enrolled are being trained in practice in the unit, also specifically in the gut health group are doing. We process of charting feeding management, and I know David Quine's been very involved in this, particularly as a year or two into, I'll talk to you about this perhaps in a minute, a year or two into introducing a chart to record our decision relating to feeding management. The SIF trial came about, and David Quine is our local PI, and we built that into our feeding charts. Did antibiotic stewardship. We tried to take that forward again, realizing that as well as being important to infection, it's important to gut. Include an auto-stop procedure for babies who didn't necessarily need a prolonged course. Again, donor breast milk, we updated that. We've done work on kangaroo care, and we've put a whole lot of new pumps for home learned by mothers. List, if you like, of things which is perhaps not all that useful. Just pick one or two things out of that. I picked out the preterm feeding chart, and I've told you a little bit about the background to that. Their way of making people on the shop floor accountable for what decisions they make on feeding. How often have you stepped into a neonatal unit having made a plan and found that there were sorts of reasons why the plan is deviated from? And there are very good reasons for deviating sometimes, but it should be to be able to say the process that actually goes on with feeding and feed increment and whether a baby gets donor breast milk or not. We decided the only way to do it was almost be prescriptive about it. We have a daily way of recording feeding on a chart by the baby's bed until the baby's on full feeds. And this records a set of simple questions that are primarily answered at the time of the ward round in the morning. Is the baby ready to be fed? And that's important. If there's a lag between the readiness to be fed and actual feeding starting, then you've got to ask the question, why is there a delay? Because the hour or day that you delay means a longer period of lines and TPM, and that's a price to pay. So what feed advancement regimen, like, you know, how fast would you like the feeds to go? And at that stage we had a standard regimen and a slower regimen that we used to employ for babies at particularly high risk, babies with absent or reverse end diastolic flow. Those were very small for gestation. These were very ill, for example. So what advancement? There's no excuse for coming along the next morning saying, well, I said such and such. So record and put a name to it. What is the hourly volume of feeds? What is the next increment? Record that so the nursing staff at the cot side can actually to that and actually make sure things go up and have a good reason for incrementing. What is the ability of express breast milk like? Do we need to work harder with the parents? Have you a decision or not to use donor breast milk? Is this a baby who would qualify for donor breast milk if there's a shortfall of express breast milk? And stopping or slowing feeds. So you sign up to any situation where you deviate from a steady process of following the regimen. And have you justified having a central line in this baby? And if so, has the consultant signed into that, and similarly with with pro-nutrition. And carrying on the graph, really, you can see that what seemed to be a job well done, that continued for a while, whatever the reason was, whether our putting together the Neonates Collaborative and all of these multi-dimensional quality improvement projects together made a difference. The Necrotising Enterocolitis rate continued to come down, but then it reeled off, and we've even had this blip back up. And we've got to be careful about looking at cases year on year, because we're really talking about less than 10 babies a year. So there is bound to be an up and down, but we're hovering close really to the mean for the Oxford network and not going any further. So have we reached a watershed in have we reached a plateau which will forever be never have to stick to in our unit, or is there room for further improvement? Others would suggest that there is room for further improvement. And when that kind of thing happens, I guess sort of pause, and you've got to go away and think. And I think a lot of the things that have been written about quality improvement come in handy, because you can get very lost in your process that's going in your own unit, and not be willing to kind of get it shaken up by looking at people's ideas. And for example, the Agency for Healthcare Research and Quality in the States have suggested that 3 tips for facilitating. People have written endlessly, whether you look at papers, books, whether your preferred medium is Twitter or whatever. People will talk about the pains of quality improvement and what it takes to have a quality improvement process. So what the for Healthcare Research and Quality says, priority on encouraging communication, engagement and participation of all the stakeholders. Start implementation with small-scale demonstrations, and keep in mind and remind us that QI is an iterative process. So we felt we'd reached a watershed. We made to kind of think and have ourselves shaken up. And if anyone around Scotland wants to come and talk to our team about what they've done, I'd be more than happy to host you, because I don't think we've cracked it by means. So what I wanted to do is kind of focus our quality improvement a lot more, rather than send it in many different directions. And we thought this was worth doing, because we felt that, sorry, again, put the wrong button. We felt that there were certain areas in the list of interventions I looked to the literature for that might be more important than others. And we just not, and for better or worse, to focus on breast milk provision. On the other hand, it's very highly evidence-based. On the other hand, if you ask the question of where are we now, you might say, and I'll show you some graphs to show you this in a minute, we've reasonably high rates of mothers' breast milk provision in the first few days, in the first week of life. But nevertheless, we looked at this and we thought, let's focus on this a bit more, because there's more work we could do. And we used a poster, really look at the whole journey of maternal breast milk. It's one way of thinking about it. Realize this is still a very large area for quality improvement that crosses many clinical areas, antenatal as well as postnatal, neonatal unit as well as antenatal and postnatal wards, midwives as well as neonatal professionals. This is enough in itself, I think. And this that really our trainees did to shake us up. I think this is a better at a driver diagram, although the purists, and I'm sure Colin will have a different take on driver diagrams in purist form have primary and secondary drivers and so on. We wanted for our staff on our unit to visualize and their thought to what is the pathway of maternal breast milk? What are the steps that we can influence the supply of breast milk? What are the things that end it to happen better? What are the things that drive it towards the negative side? And I think I wouldn't go through each of these headings, but it goes from threatened preterm labor, at labor ward, labor and delivery, neonatal ward and postnatal ward, which is kind of where the baby split, if you like, and that is particularly a challenge, as well as this time before delivery, and that's the postnatal course and discharge. So it changes each step along this way, and I thought this is a good way of trying to engage the people not yet been brought in. And what we're hoping to do, a lot of what I've got to say to you is what we have ambitions to do is look at this with the nursing staff on the shop floor, print this out as a poster, and actually trying to get them to say, oh, no, well, that's not really our challenge. Our challenge is more such and such, and actually get them engaged more in the process of improvement, and then decide a little time to do a specific project, lay with the postnatal ward staff in addressing these particular negative drivers for effectiveness on the postnatal wards. Just very quickly going through, this is our run chart for maternal breast. This is a VON from Oxford Network, babies less than 24 hours. What your graphs I show you is a steady period of improvement, a stalling, and that's not inevitably, but more recently a fall off in success. And so this is quite a timely time, if you like, for us to set up and reinforce our quality improvement processes. This is maternal breast milk in the first 24 hours, and we're still some way short of our target most of the time. Sorry, these are monthly dots. The six monthly mean shown as the blue line, a target that we arbitrarily, if you like, set is the green line. Maternal breast milk in the first 72 hours. This is an important graph, I think, because it shows that whilst we're pretty good, and we often get to 95% of our babies getting breast milk in 72 hours, we're no like as good in the first 24 hours. And that's something we want to spend time trying to improve, because there are units, particularly in the States, which manage to do that. This is exclusive breast milk on discharge in inborn babies, and this is much lower. And of course, this relates partly to the way we approach mums, often saying to them that extracting your milk doesn't commit you to continuing to breastfeed on an ongoing basis. But there is, again, who've said they've managed to, it's not just all about geography and socioeconomic deprivation. There are some units that have systematically managed to improve their discharge breastfeeding rates, and we want to try and mimic that. It's really our mission in the future is to try and work on early access to breast milk, that early phase, and to work on sustaining breast milk expression. And those two things I think we've not had our eye on in the past. This is another way of showing it. This is any breast milk at discharge. Neonatal unit. And again, dwellings just take on board the fact that we've had periods when we've improved this, then stalled, and more recently all our figures have slipped a bit. I'm not saying that they're bad. They compare favorably to to benchmarking, but I'd like to do better. Finish off very soon, just to point out there is evidence base to this. So there is evidence that early effective expression, so expressing breast milk, certainly within 6 hours, if possible, starting to do it earlier, important, and then the program itself probably beneficial in feeding, and if you can label separately and feed it in preference, particularly in the first day or two, that have the protective effects that you particularly need for your gut barrier. And there is recent evidence that you can do this, and we do this regularly now. We won't have sufficient volume to give milk in a nasogastric tube. We use the colostrum for mouth care. And in babies who are too sick to have intragastric feeding with milk, we give mouth care. To go through all the evidence, but Paula Meyer is the person in the Rush Natal Center in Chicago who's done most of the work on this, although this is potentially, you could think, out of date. I don't think the science has changed hugely in that time. He's written this paper, Improving the Use of Human Milk During Our Decay, and evidence that the bits of maternal EBM are dose-related, and the period of exposure might be, or probably is, the first 14 days. So if you're setting yourself a measure that you should look at, in addition to the neonatal audit program measure of discharge breastfeeding, which is rather crude, what you should look at is how portion of the feeds are maternal breast milk in the first 14 days. Let's say early expression, frequent expression, empower parents with information, kangaroo care, the use of electric pumping and double pumping and emptying the breast, protecting parent peer waters, which is a thing that they do in the Rush unit in Chicago, are things that you might think about. A recent graph, I'm sure, sorry, it's probably a little blurred because it, but kangaroo care showing the monthly rates, the median in past years, in 2015 particularly, was 20%. This is a little bit out of date now. It's quite out of date. 2016 is the latest. But it needs quite a lot of number crunching from Bajonet to extract the data to see what portion of our babies get kangaroo care. But our median widgets, the first arrows, the setting up of a QI group. The second is using a guideline, and here's a poster educational process for staff, and median rate of group care certainly stepped up to more like the 30%, although we like it to be much higher because it's one of those processes that is known to be linked to good success rate of lactation. There, I tried to time it so I had some time for discussion. I know we started a bit late. If you have quality improvement is a bit like climbing Everest, we're very much at the falls. Probably wrong analogy in many ways because you never stop climbing with quality improvement. But really our story in Edinburgh, I'd be very happy to take any questions. Thanks.
Thanks very much, Gopi. That was fantastic. I'll kind of make a little comment before opening it up to the floor for some questions. I think it's worth saying that you understand yourself as regarding your expertise in quality improvement, because you pick out some of the really important aspects that we talk about a lot at the SPSP in the quick program. So about, for example, getting those quick wins in that can make a difference, and picking items that have the greatest size of effect. Well, if you already have measurements before, we'd say plot those on a Pareto chart, but if you don't have the measurement already, then yes, by all means look at the evidence. Communication and collaboration, very much what we've been talking about and emphasising in our most recent neonatal networking event. And your trainee's diagram of the positives and negatives is perhaps unwittingly or unknowingly a process map. We actually know that if you take a process map and turn it sideways, actually pretty much becomes a driver diagram. So you're very much there. You talk about a broad range of processes, and I think that was recognised by the groups that were looking to establish what could the neonatal part of McQuick do to improve NEC, and we bundled some of those all together into a package of perinatal care. So looking at giving steroids, magnesium, delayed cord clamping, optimal temperature, milk first 24 hours, and caffeine. So that's our preterm perinatal well-being package, and most people have seen hopefully that, and perhaps now the updated one at the networking event.
That's a really good idea, and we in our unit, what we've decided is that, although it's early days yet, we've decided that we incorporate it into our weekly review meetings. So the beginning of every meeting where we review cases, either deaths or cases which have been deemed worthy of review, at the beginning of that session, our coordinator looks at any case where any one of those items on your checklist haven't been implemented, and we look at the cases in the maternity notes and the neonatal notes to see why that hasn't been there.
Yeah, that's certainly something we've recommended alongside that in our measurement plan. To be circulated in the very near future is our specific necrotizing bundle, which is avoiding formula in babies up until they are 32 weeks, and as you described, having a documented feeding plan according to your local guidelines until babies have reached full feeds, which would meet the addition of 150 mils for 40 days. So
about that, I mean, I think one way of looking at it is avoiding formula. And there are a number of people in the States who have interpreted research evidence as suggesting that formula is harmful. I don't believe there is data to show that, but what it does show is that if you replace formula with breast milk, that is a good thing. And so we've focused on giving access to maternal breast milk, which as a side effect will lead to avoidance of formula.
Absolutely, absolutely. So much as Gopi, I could talk to you this topic on my own for quite some time. I think we should open up to the floor and ask if anybody has got any questions.
So, Gopi, I'll add in my thanks again. That was fascinating. It was really, really good to listen to. I've noticed we've got a question on the chat from Jackie Welsh, who has asked how easy was it to get parent representation onto your gut group?
Parent representation is always a thorny issue, and as you know, in healthcare as a whole, people don't really know what it means. So, we for some years had parent representation on our quality collaborative, but the issues is that there's no easy way that you can a parent that is representative. You might not think, for example, that the people on the BM Executive Committee are representing neonatal professionals, but there's no process by which you can elect a parent representative to represent all parents. And so what you end up doing is process a parent who's able to verbalize thoughts about what's good and what's bad in the process. So I really just asked one of my colleagues who does the 2-year follow-up, a parent who seemed enthusiastic to be involved and who expressed an interest themselves. I just said, would you contact them and say, would you mind if I got in touch? And really enthusiastic. So being democratic in this process. But it doesn't stop you involving, because I think they can add a huge new dimension. That answers your question. Listen to you.
Yes, no, thanks. It does, says Jackie. She obviously doesn't want to hear herself speaking or have anybody else hear it in the future on the recording of this. Anyone else have any questions for Gopi?